Hi everybody, thank you for joining me for this talk today. My name's Alister Bates from Cincinnati Children's Hospital. Thank you to the organisers of SCONA for inviting me to talk today. I'm going to focus today on the obstructive sleep apnea in children, and particularly how neuromuscular control relates to disease severity. So sleep apnea is collapse of the airway during sleep. It can happen in a number of different locations, shown in these images here. But targeting these anatomical locations, so if you think there's not enough room in the airway at a certain place and then doing a surgery to correct that, actually leads to poor surgical success rates. One of the reasons for that is that it doesn't take into account neuromuscular control of the airway. So the airway isn't just passive. If you try and breathe and you don't get enough air in, your airway will try and you'll try and move the muscles of the tongue and the soft palate surrounding the airways to make more space. And we think this neuromuscular control of the airway is just as important as the anatomy, but is not currently clinically measured. I think there's a way of measuring neuromuscular control using CFD, and that's what I'm going to focus on today. So to do a CFD simulation of a disease that involves collapse movement, we need moving boundary conditions. So I'm going to briefly talk through how we get those. To start off, we'll go with some static boundary conditions, just like any other CFD simulation. We segment an airway from MRI, and we end up with a high resolution static surface. So how do we make that move? Well, what we do is we do fast cine imaging. So this means we're getting a 3D image of the airway about 3 times a second. And from the cine image, we can use a process called image registration to map the motion of each piece of anatomy from one frame to the next throughout the breath. If we do that across the whole image, through the whole breath, we end up with a 4D motion map that we can then apply to our surface that we segmented, and that gives us a moving wall boundary condition. So throughout the whole breath, we know the position of the airway. And of course, we need one more boundary condition to do CFD, and that's the flow rate. And that's why this patient's wearing a mask. There's a flow meter here, and that measures the air coming in and out. And this is synchronized with the imaging. So each vertical red line here is when we take an image. So we know for every image in our cine sequence exactly how the patient was breathing. We put all that together, and we end up with 4D boundary conditions that vary across one breath. But does it give us the right answer? We wanted to compare our velocity fields from CFD to something that we could measure in vivo. There's been lots of people have done studies where they've compared CFD to models. We wanted to see if we could do this in vivo. So we wanted to use a technique called phase contrast MRI, and that means producing a velocity map from the MRI data. This is used all the time in cardiovascular medicine, where you can see the velocity of blood, and this is what this image here is. This is the velocity of some blood in a rat. But of course, blood is much more dense, has many more protons than air, and we don't get enough MRI signal in air to do the same thing. However, if we inhale something that we can see on MRI, and we choose hyperpolarized xenon gas to do that, we can inhale the xenon, and that will show up on our MRI scan. So if we do a regular proton MRI, we see the airway just as you would expect, the airway in black. If we inhale xenon, instead of seeing black where the airway is, we see signal where the airway is and black everywhere else because there's no xenon anywhere else. Then if we do phase contrast MRI of that xenon, not only do we see where the xenon goes in the airway, but we also get a map of how fast it's moving. And that velocity map is equivalent to the velocity maps you produce during CFD. So now we can compare the velocity map we get from the inhaled xenon phase contrast and the velocity map we get from our CFD. And that's exactly what we're doing here. So we are looking at the same airway, and we see broadly the same thing. We get from the nasopharynx down to the top of the trachea, we see the air moving in. There's a jet that comes to the back of the airway, fastest moving flow at the tip of the epiglottis, stays to the back of the airway, and so, accelerates again through the vocal folds and down into the trachea. They're not exactly the same. The jet is smaller in the CFD case than the phase contrast case, and this is to do with small movements of the patient. So it's very hard to keep the subject in exactly the same position as we change MRI equipment from the proton for the CFD to the xenon MRI equipment. And of course, even if we didn't move the patient, they still move the structures of their airway in between images. So we get slightly different results as the tissues move slightly. But if we compare the velocity at each voxel from one to the other, so we're just plotting CFD velocity against phase contrast velocity here, we get pretty good agreement. It's not perfect one-to-one agreement, as I said, but it's certainly statistically significant agreement. So we were reasonably happy with that our simulations are accurate and are continuing to use them from that. So how can we get back to that neuromuscular control, and how can we calculate neuromuscular control from CFD? Well, it's all to do with the movement of the airway and the air pressure that's acting on it. So what we're seeing here is the airway, this is a real sleep apnea patient, and the red arrows just show us how the airway moves through a breath. So the red arrows are showing each patch of airway surface and how is it moving. Is it expanding, contracting, translating? The blue arrows show us the pressure force. So from the CFD simulation, we get a pressure field through the breath. So the blue arrows show us through the breath when is the patient inhaling and creating a low pressure that's sucking the air in, trying to collapse the airway, and then exhaling, pushing the airway out, trying to force the airway out. These are the forces that the air is causing to act on the air pressure. Well, now we've got a velocity and a force, and if we multiply velocity and force together, as you know, we get power transfer. So is the air transferring air energy to the airway wall or vice versa? And that's what we're seeing in this third image. And what we're most interested in is the direction of the transfer. So if the air pushes, if the air pressure is pushing on the airway wall and the airway moves in response, that's just a passive response. So just as if the airway's moved made of rubber, and that's what we're going to color in red. Anywhere where the red arrows and the blue arrows are pointing in the same direction at the same time, we'll color that red, and we call that passive motion. The air is just pushing the airway or pulling the airway in a certain direction. But if the body's responding and the airway's trying, the muscles are trying to fight against the air pressure, they'll move the airway in the opposite direction. And that's what we're going to color blue. So if the red arrows and the blue arrows are pointing in the opposite direction, we color it blue, and we call that active motion. There's only two things that can cause motion in the airway. Either it's passive response to the air pressure, or it's neuromuscular control. So we've really separated the two causes of motion into passive response in red and neuromuscular control colored in blue. And that's what we're showing in this third image here. Again, we didn't want to just sort of believe this. We wanted to do a validation, and this time we did do a model. So here's our 3D printed model of an 11-year-old, and it's pliable, so we can move it. We wanted to move it in a very controlled way, so we put it in a pressure chamber, and rather than try and recreate all the many muscles that control the tongue and the soft palate and the epiglottis, we just put it in a pressure chamber, and that gives us one big muscle to dilate the airway with a negative pressure. So if we make a low pressure on the outside, it will dilate the airway. If we make a high pressure on the outside, we can collapse the airway and get it to shrink. So we've just got big muscles, like as if there's one big muscle acting on the entire outside of the airway. So we have our airway in the pressure chamber, and then we attach it to a cough-assist machine. That's basically a fancy ventilator. So the airway is going to breathe. The nose is connected to atmospheric pressure. So the airway is going to breathe and move as it breathes, just as a real airway does, but then we can turn on and off these giant global muscles on the outside. And what we want to do is, can we tell why the airway is moving? And predict, in this case, we'll know whether or not we turn these muscles on and when we did that. We won't know that in a real patient though. So can we use our power transfer metric that I described a couple of slides ago? Can we use that to predict what the muscles are doing? If we can get good agreement here, then hopefully that means we can use power transfer to tell us what's happening with muscles in a real patient. And that's what I'm showing in this third slide. This third image. So the power transfer, that's what we're measuring in our CFD simulation. We see the graph here with a nice peak. And here's in the same run, we did lots of runs where we turned different pressures on at different times, different muscles on at different times. Here we get a peak, just the same. And we actually, if we compare these two graphs statistically using cross correlation, we get really good agreement between the two graphs. And so this means we can use our power transfer from our CFD to predict or to tell us what's happening with the muscles. This is done in a global way, but in real subjects, we can do this on a muscle by muscle, or not muscle by muscle, but a structure by structure. So we can use our power transfer to tell us what's happening with the tongue and the epiglottis. And that's what we've done now in 18 real subjects. And we wanted to see, does the motion of these structures correlate with disease severity? Now, in sleep apnea, disease severity is measured by obstructive index. That's the number of times you stop breathing during sleep. So you might assume if you've got a really floppy soft palate that just collapses every time you breathe in because you've made a low pressure, that would correlate with having bad sleep apnea and a high OI. And yes, indeed it does. We saw that if you've got a really passive soft palate, you will have more likely to have a high OI, bad disease severity. The same is true in the epiglottis. But we also saw that having lots of neuromuscular control also correlates with obstructive sleep apnea, having severe sleep apnea. So why would both passive and active muscular control both correlate? And what it turns out is we see two phases of inhalation. As you start to breathe in, the airway collapses. And of course, the body responds to that. So the body's fighting against that collapse. It wants more air in. So it triggers the muscles of the soft palate and the epiglottis to expand the airway and allow more air to come in. So we see an early collapse and then a response to it. And both the collapse and the response correlate with having a high OI. So we're really learning more about the physiology of sleep apnea through CFD simulations. Interestingly enough, the tongue was not significant in our group of 18 patients. The tongue is often the focus of these surgical responses. So it was really interesting to us that actually the soft palate and the epiglottis looked more significant. So I'm going to leave our talk there. Hopefully I've shown that there's an interesting link between CFD simulations, neuromuscular control, and disease severity. I need to thank Chiwei Zhao, who did all the simulations and really leads this sleep apnea project for us. And of course, Dan Ignacek, who is our clinical expert and tries to make sure all our engineering is clinically useful. And also did all the validation for the neuromuscular control. And I also want to thank Neil Stewart from the University of Sheffield, who led all our Xenon validation work. The last thing I want to say is that we are expanding our group and we are looking to recruit both postdocs and PhD students. So if anyone is interested in either the work I've done today, the validation, the Xenon, the sleep apnea work, or the work that Chaminda Gunatilaka is going to present in terms of neonatal breathing and the breathing of those really premature babies, do please get in contact with me. My email address is alister.bates@cchmc.org. I'd love to hear from you. With that, thank you all very much for listening, and I hope you enjoy the rest of SCODA.